Very good afternoon to everyone. I feel privileged to have you all here for this insightful session on oral cancer awareness, an initiative by Epillo Health Systems. I would like to inform our audience that Epillo presents a series of candid conversations on various health and awareness related topics that help everyone lead a healthier and safer lifestyle. This is our sixth episode in which we will be covering fundamental aspects of oral cancer to spread awareness. According to the US National Library of Medicine and National Institute of Health, oral cancer is the sixth most common type of cancer worldwide, and India contributes to almost one third of the total burden, and the second country having the highest number of oral cancer cases. The risk of oral cancer can be due to an overall effect of aging of the population and some regional differences in the prevalence of specific risk factors. Therefore, to improve oral health and promote oral cancer awareness among people, we plan a panel discussion covering the fundamental aspects of oral cancer. And I am profusely delighted to invite our panelists for the session, Dr. Rubia and Dr. Praveen Jain, who gathered the time for today's session despite of their busy schedule. Dr. Rubia is a dental surgeon and the director of Epillo Health Systems. She is also a public health researcher and has contributed and attended various health management and development programs. Dr. Praveen Jain is an MBBS and senior consultant and HOD of medical oncology with Aakash Healthcare Superspeciality Hospital, Dwarka. He contributed to various publications, informational letters, and case reports. So, without wasting any more time, let's uncover the social dilemma of oral cancer because you matters, your safety matters. Now, I would like to request my panelists to take over the virtual stage.
Afternoon, everyone. So, first of all, I would like to welcome Dr. Praveen Jain, and we are going to have a little chit chat about the oral cancer awareness. And so, I would like to ask you, Dr. Praveen, so what are the different types of oral cancer, and what are the stages of oral cancer? Please tell us about it.
So, first of all, thanks a lot for the warm welcome. And this is such a platform where we can discuss about the various aspects of oral cancer, and we will create certain awareness so that the patient, they become aware of the risk factors, they become aware of why they develop oral cancer or maybe some other cancer. And I think this is going to help in a real way and in a practical way for all the people. So thank you, Rubia. So first question, as you told, what are the types of oral cancer? So usually we talk about the head and neck cancer, and head and neck cancer, it depends on, so from which site it is originating. So we call it that particular cancer, like oral cavity. So it is called oral cancer. So if it is arising from the pharynx, so it is called pharyngeal cancer. From the voice producing organ, which is called larynx, so it is laryngeal cancer. So oral cavity in particular, so we have various structures in our oral cavity. So starting from anteriorly from the lip, posteriorly to the anterior border of the tonsillar fold, then laterally the buccal mucosas, and above the palate and below the floor of mouth. So all the content of this particular area, so they are termed as oral cavity sites, and whatever cancer develops, so that is called oral cancer. It can be a lip cancer, it can be a buccal mucosa cancer, it can be an anterior two-third of the tongue cancer, it can be hard palate or floor of mouth cancer, or gingivo-buccal region cancer, or retromolar trigone, or gingivo-buccal sulcus cancer. So these are the type of oral cancers which we know. Apart from that, regarding the stage of oral cancer, so there are 4 stages: stage 1, stage 2, stage 3, and stage 4. So broadly speaking, oral cavity cancer, they are classified into local cancer, localized cancer, then loco-regional cancer, and then the metastatic ones. So stage 1 and 2, they are usually called early stage cancer. So here the size of the tumor is less than 4 centimeters, and there are no lymph node spread of the cancer. So you don't have any tumor in the neck, only oral cavity lesion is there, so which is less than 4 centimeters. So that is a stage 1, 2 cancer or early stage cancer. So if the cancer has already spread to the neck region and it is on the same side of the tumor, so then it is usually called a stage 3 cancer. And if it has gone to the opposite side of the neck also, so then it is usually called stage 4A cancer. So 4A cancer or 4B cancer, these are loco-regionally advanced cancer. And if the tumor is like originating from the oral cancer and it is involving some other site, like if it is involving the nasal cavity or it is involving the posterior part of the tongue. So usually these are the loco-regionally advanced cancer or stage 4A or 4B cancer. And the 4C category is those cancer who spread from oral cavity to some other viscera in the body or some other organ in the body. Like if the most common site of metastasis is the lung metastasis. So if your oral cavity cancer has spread to the lungs, so that is called 4C cancer, stage 4C. And or be it liver metastasis or bony metastasis or any metastasis which is into some other organ of your body, so that is called a 4C cancer.
All right. So, as we know that there are no specific detection solutions or routine screening tests for the oral cancer, right? So, but can you describe a little more about the early detection test for the oral cancer or any kind of cancer which is related to oral cavity or the larynx?
As Charu rightly pointed out, the health problem which we are facing right now. So, Indian population, there is a habit of chewing tobacco, smoking. So these are the two most common risk factor for oral cavity cancers. And as such, the biggest problem with us is that there is no one solution for like early detection of oral cavity cancer. The one modality which we often use and which is recommended by Government of India, so that is the orovisual examination. So in this, a person has to come and usually we do these sort of oral visual examination in the high risk population. So which are high risk population? So the high risk population are those who are smoking for a very long time or who are chewing tobacco or who are consuming alcohol or areca nut or betel nut. So apart from the tobacco chewing, so these areca nut and betel nut, so this is very, very prevalent in our rural population. So because of which a person develops usually some type of symptoms like oral ulcers which are not healing or some sort of growth or nodule or fixity of the tongue. So these all the problems they comes and usually these are avoided. So these are not taken very well taken care of because they do not have access to the health care. They do not have access to the dental care also. So then comes the role of orovisual examination. So Government of India says at least, so there are three kind of guidelines which are made for this. So one is for a population like our rural population, so who do not have access to the healthcare or dental care. So at least these high risk individuals should be subjected to 3 orovisual examinations in their lifetime. So in orovisual examination, it can be done by any of the health worker. So usually they, in adequate light, they see the buccal mucosa of the oral cavity, they see the floor of mouth and tongue. So whether there are any reddish patch or white color patch or any growth or any ulcer, and then they can inquire about the same lesion since when this lesion is persisting. So this is called orovisual examination. So the ideal thing is to get orovisual examination in these high risk individuals every 2 years. But the least is at least 3 orovisual examinations in the lifetime. So this is the recommended screening method for oral cavity cancer. In India, because we have a lot of oral cancer, and oral cancer is the second or third highest cause for cancer in India. So this is something which is recommended. Apart from Indian setting, so there are some other countries like Cuba or South American countries where the incidence of oral cavity is high. So they are definitely proceeding with orovisual examination. But apart from these two continents, Asia and South America, so there are no set guidelines for screening of oral cavity cancer.
Okay. So do you think, are there any strict guidelines about the oral hygiene in India as of now?
So if you talk particularly about the oral hygiene in general, so I think I'm not aware of any guidelines. So do you have to get a dental checkup done every year or like that? But yes, in children's definitely there is a saying that a lot of children's they have cleft palate,
Yeah.
poor oral hygiene, then ill-fitted denture in the adult population or the elderly population. These can definitely lead to poor oral hygiene, and they can lead to further development of some infection or cancer or other problems related to the dental hygiene.
Yeah, right. So, Dr. Jain, you rightly explained that high risk individuals who are consuming alcohol or smoking cigarettes or continuous use of tobacco, they are more likely to develop oral cancer. So, according to sources, that oral cancer has some effect, is more prevalent in females. So, it doesn't have any effect on fertility of the females or having children. How does it affect it?
So yes, we talk particularly about the worldwide scenario. So it is more common in females, and I think 60% or 65% of the oral cavity cancer they develop in males. If we talk particularly about Southeast Asian countries or particularly about India, so the majority of our patients with oral cavity cancer, they are males because of the prevalence of habits of tobacco smoking, tobacco chewing, or other things in predominantly in the male sex. But regarding the fertility issues, so these kind of fertility issues, they usually are there in both male and females. So it is not about the female infertility, it is about the male infertility also. And usually it is about the treatment which causes the infertility part. So surgery doesn't cause any infertility, radiation therapy doesn't cause any infertility, and most of the times head and neck cancers or particularly the oral cavity cancer, they are receiving local modality like surgery and radiation therapy. So their infertility is definitely not an issue. So yes, with radiotherapy, there are certain like things that there are scattered radiation which goes to the gonads, and that can lead to fertility issue. But nowadays with the advancement, so the radiotherapy machines are also so there are such a good protocols. So where there is IMRT, that intensity modulated radiotherapy, where the particular amount of high dose is given to the high intensity areas where the tumor tissue is more, where the tumor bulk is more, and the low intensity radiation therapy is given to the other areas. So they are highly conformal radiotherapy techniques, and with these radiotherapy techniques, the risk of infertility with radiotherapy definitely is very, very less. But yes, if we talk about chemotherapy, so there are chemotherapy agents which can lead to fertility issues, and the gynecology field and the infertility field also has advanced to a great extent. If we talk particularly about infertility, so methods to preserve fertility in males. So that is a very, very simple and straightforward method. So in prepubertal males or females, so there is a new experimental thing which is coming up, that is the tissue cryopreservation. So they take out the testes and they cryopreserve in males in the prepubertal, means the female or male, so which are of less than 13 year of age, where the puberty has not happened, and the ovaries, they are not fully developed, so you cannot take the ova out of it. So there you can preserve the ovarian tissue as such. You can cryopreserve it. So this is regarding the prepubertal. But most of the times, these prepubertal male or female, they do not have head and neck cancer or oral cavity cancer because they do not have this risk associated with them. And most of the cases of oral cavity cancer, they are associated with these risk factors. So now coming to adolescent age group, male, it is straightforward that you can do semen cryopreservation. So male gives the semen and that can be cryopreserved and that can be used in a later setting for the fertility things. In females, it is a little bit tricky. So again, coming to the age of the females, like those females who have a partner, so those females who are married. So the best method of fertility preservation in these females, that is embryo preservation. You take out the egg from the female and you take the sperm from the male, you fuse them, you make a embryo, and then you cryopreserve it. And that can be used in a later time. If a female is of adolescent age group or unmarried, so you do not have the male partner. So what you can do is that you can just take the ova from the female ovary and you can cryopreserve it. So that is oocyte cryopreservation. And the third one is, as I told, because these are slightly tedious method and it takes time to do this ova preservation and embryo preservation because it all depends on the menstrual cycle of the female. And when you get to know about the oral cancer diagnosis, so you want to treat it as soon as possible. So you do not get the time to do the embryo preservation or oocyte preservation. So there another method is to give certain hormonal injections like gonadotropin releasing hormone agonist hormones. So where you are able to suppress the function of ovary, and I think at a later time you can there are some chances of regaining the fertility if we give these injections along with the therapies. So I think it's a very complicated topic.
It is, it is.
Fertility preservation, but yes, those people who are facing this problem and they are very, very keen in fertility preservation. So it is a definite need of those patients and the doctor, and this need has to be met. So this is a very, very important question and very good question which you had put forward.
So that was really a lot of useful information, and you have really explained it in a very nice and simple manner. I hope it's gonna clear a lot about the stigmas which are related to fertility, be it for males or females. So there is another stigma attached to cancer, or when it comes to chemotherapies or any kind of radiation therapies. So what could be the expected side effects of any radiation therapies or surgeries?
So as I told you previously, most of the head and neck cancer or oral cavity cancer who are stage 1 to 4B, I'm not talking about the 4C where the disease has already spread to the liver, lung, bones, etc. So in these loco-regionally advanced cancer or localized cancer, the main modality is surgery or radiotherapy. So broadly, if you speak about the toxicity of surgery versus radiotherapy, surgery, it has got more side effects, acute side effects, and less long-term side effects. Radiation, it has got both acute side effects also and the late side effects also. So surgery, if we talk about in oral cavity, the side effects are mainly related to the local issues which arises after surgery, like bleeding, like some sort of infection, or many a times a reconstruction is done whenever we take out a lot of disease portion. So we need to reconstruct the defect also. So many a times the loss of flap or the loss of reconstruction. So whatever tissue we have used, so there is sometimes loss of that tissue. So these are the main acute side effect of surgery. And if we talk about the late side effect of toxicity of surgery, so those are broadly classified into two groups. So one is the cosmesis related side effects, and the second is functional impairment. So cosmesis related, that because you use, like in oral cavity buccal mucosa cancer is there, you use free flap, and there is a defect whenever you take out the buccal mucosa. So buccal mucosa for like the cheek cancer. So you take out a full core tissue, the cancer tissue, and then you place a graft over it, a free flap over it. Then so there is a tissue which is not exactly the tissue of the cheek. So it definitely gives a cosmetically poor outcome as compared to those patients who have a early cancer, where only the surgery is done from the transoral route, and skin incision is not given. So this is regarding the cosmesis. So regarding the functional outcome, so many a times, like in a tongue cancer, so you excise the tongue, so anterior 2/3 of the tongue. So subtotal glossectomy is done. So these patients, they do have some problems in speech, some problem in swallowing, because tongue is having two functions for us. So in fact, three functions. One is the taste, second is the swallowing function, and third is the speech function, the speech modulation. So all three functions, they get hampered when you do a subtotal glossectomy. So there is a flap which is placed in place of anterior portion of tongue, and usually the speech part improves after that. People, they need rehabilitation, but speech part improves, the swallowing part improves, but the taste part definitely becomes an issue, because these flaps or these prostheses, they do not have the taste buds. So this is regarding the functional impairment. So you asked me about the larynx cancer. So larynx cancer also, if you take out the larynx, so total laryngectomy if it is done, so then there are issues with the speech. So there are a lot of things which are available nowadays to improve the speech outcome. So that is also a thing which you have to see when you are proceeding with surgery. So these are the surgical complications. If we talk about the radiation toxicities, so acutely the radiation toxicities are just like skin burns, then oral mucositis. So because of which there are burns in the oral mucosa also. The dysgeusia part, because of these burns, patient is not able to have the taste. Like in COVID scenario, all of us, they have faced anosmia and lack of taste also.
Loss of smell and taste.
These kind of problem, they come acutely during radiotherapy or immediately after radiotherapy. And acute toxicity, they are defined as those toxicities which are arising in the first 90 days of the treatment. Apart from the acute toxicities, there are late toxicities which are very, very important in terms of radiation toxicity. So first and foremost is the xerostomia. So there are salivary glands which secrete saliva, and this saliva helps in swallowing of the food, and this helps in reducing your chances of getting infection. So because see, oral cavity, in oral cavity secretion, there are a lot of bacteria, virus, because these are the first point where they get access to our body. So this saliva, it has got antiseptic properties, which reduces your chances of getting an infection. And when these salivary glands, they are given radiation, so they stop producing this saliva. And because of this dry mouth, you get a lot of fungal infections, you get a lot of other infections, you get mucositis, oral ulceration, repeated oral ulcerations, difficulty in swallowing. So these are issues which comes later on with the radiotherapy. Apart from xerostomia, so there are a lot of therapeutic modalities which we use for xerostomia. I don't think so we should discuss about it right now. So apart from xerostomia, so there are some late side effects of radiation, like there is thickening of the skin, so which leads to skin fibrosis and subcutaneous fibrosis. And you can see a lot of radiotherapy people who have a stiff neck, so they are not able to move their neck. That is because of the subcutaneous fibrosis and the skin fibrosis. Apart from that, similar kind of fibrosis, they happen in the joints also. Like in your TMJ, if this kind of fibrosis happens, so the mouth opening is restricted in these individuals in the long run. So these are most of the side effects which happens with the radiation. There are lot many more side effects, but these are the main side effects which happen. If we talk about the chemotherapy, so chemotherapy also again acute toxicities and late toxicities. Acute toxicities usually they are most of the toxicities they are transient and acute toxicities which happens with chemotherapies like oral ulcerations, like loose motions, then hyperpigmentation of the skin, mucosas, then your nails might get black. So there might be some sort of abnormal sensations like dysesthesias, paresthesias. So most of the time, these are the side effects that happen. But in a small number of population, so you might get long-term side effects also, that permanent, some sort of permanent peripheral neuropathy, some heart, the side effects on heart. So these are the chronic side effect or the late toxicities of chemotherapies.
All right. So, as you talked about larynx cancer, that there might be chances of loss of voice box in some cases after the surgery. So, what are the options available for voice rehabilitation if required? Could you please tell us a little more about it?
So it's a very, very important question because many of these smokers, they develop larynx cancer.
That's right.
These people, they do not take treatment because of fear of losing the voice. So this is a very big fear, because of which majority of the people who do not take treatment, the major cause of that is the fear of losing the voice. So first of all, I would like to tell you is that there are a lot of larynx preservation approaches we have. So where the larynx is preserved and the voice is preserved in majority of the patient. So those are like giving radiotherapy, then microlaryngeal surgeries. So these are those aspects where you are preserving the natural larynx of yours. But if the case is so advanced that you are not able to preserve the larynx and you have to do total laryngectomy. So in these cases also, majority of the patients, they are able to do well with their voice, and it is possible with a very effective voice rehabilitation. So there are three kind of procedures which can be done for voice rehabilitation. So first is the electrolarynx. So electrolarynx is an electrical device. So through which a patient can just keep here or here, and that will create the waves and movements, and which will be produced by your own mouth, and your tongue can and tongue and oral cavity structures, they can modulate the voice. But the problem with electrolarynx is that the sound produced by electrolarynx, it is very monotonous. It is just like a robotic sound. So you might have heard of robots. So they talk about what is your name. So this kind of tone is there. So electrolarynx, and after that there are two kind of approaches. One is the esophageal speech and one is the tracheoesophageal speech. So I think the best modality is tracheoesophageal puncture. So it is called TEP. So what you do is that after taking out the larynx, a puncture is made and a connection is made between the larynx and the pharynx, and you put a valve there, one-way valve, so that only the content, the air from the larynx can go to pharynx, and the pharyngeal content, which are like our food particles and all, they should not get into the larynx. So this is a kind of there is a kind of prosthesis like valve which is inserted, and with this and proper rehabilitation, patient is, they are able to speak as normal as they were speaking previously. So this is as good as a normal person. So, but yes, it requires 3 to 4 months of rehabilitation exercises, so that the person is able to produce a comprehensible and a normal volume, normal tone sound.
That's wonderful that with all these reconstructive therapies, one can, retain or resume their voice. So, doctor, what are the chances of recurrence or developing a secondary cancer after the first diagnosis?
So see, the chances of recurrence is something which is separate from the secondary cancer. So these patients with oral cavity cancer or presume it to be a head and neck cancer. So most of the times they are because of some risk factor. And this risk factor, they all the mucosa of ours, be it buccal mucosa, be it tongue mucosa or the pharynx mucosa, they are exposed to these risk factors like smoking. So which all mucosa they get affected from that. So there are some precancerous changes, so which happens in the mucosa throughout. So at one place, cancer has developed now, and when you treat this cancer at some other place, another cancer can develop. So that is called a second primary malignancy. Okay. So this is because of the field cancerization. We call it a field cancerization, that these precancerous changes, they are not happening at just the site of the cancer. So it is happening in a broader way. You can say whole of the mucosa of aerodigestive tract. So both the esophagus and the larynx. So the chances of developing a second primary malignancy in head and neck cancer, so it is very high. So it is to the tune of, so it depends on the number of years which have elapsed after the diagnosis of cancer. So if we see in development of second primary cancer in 5 years, it is to the tune of 5%. If we talk in terms of 10 years, so it is to the tune of 10%. And if we talk in terms of 15 years, so it is to the tune of 25%. And so the risk of second malignancy, it increases exponentially as the years pass by. So it is less in first year, more in second, even more in third, and maximum as you go down the timeline.
All right. So, as we know that there is a lot of monetary or cost attached to all the treatments or radiation therapies or chemotherapies. So, what are the cost-effective treatment solutions for cancer prevention in India?
Okay. So cancer prevention, it is a very, very important thing, and it is definitely an unmet need for us. If we talk broadly about the cancer prevention, so we classify it into primary prevention and the secondary prevention. So primary prevention, they mainly focuses on the risk factor abstinence. So they just remove the risk factor so that you do not develop cancer or precancerous lesion. So these risk factors we already know: smoking, non-tobacco smoke, or like chewing areca nut, betel nut, and alcohol. So you should create an awareness among the general population to reduce their risk factors, so that you, first of all, you do not get cancer. So this is called primary prevention. Then there are the secondary prevention measures. The secondary prevention mainly focuses on like early detection of cancer. So those patients who have the risk factors, and there you want to detect the cancer early. So we had a discussion over the screening for oral cancer. So that is the secondary preventive measure. So you should try to follow the guidelines for oral cancer screening. Apart from that, there are certain chemopreventive methods also, like vitamin A supplementation, vitamin E supplementation, or vitamin D supplementation. So there are some data that it might lead to improve outcome, or preventing the oral cancer to develop. But the concrete guidelines are not there in this favor. Regarding the screening per se, the oral cancer screening, there was a trial which was conducted in Kerala. So that was a Kerala oral cancer screening trial. So there they had seen that those patients who had high risk patients who had at least three oral cancer or orovisual examination in their lifetime, so they had almost 30% reduction in the mortality associated with oral cancer. So if we do it every 2 yearly, so it might reduce the cancer mortality further. And what they had observed was that those cancers which were screen detected, so those cancers were mostly of early stage, stage 1 or stage 2. They were not stage 3 and stage 4 cancers. So the chances of detecting it in early stage, it is with screening only. I think these are the very, very cost effective tools because you do not have to use any modality. You do not have to use a very, very expensive test. This is just a consultation which you can take from any health. So the thing, if we talk about the uh, uh, government steps, so I think they should make aware most of the health care providers so to do opportunistic oral cancer screening. So this opportunistic screening, it is very, very prevalent and it is a thing which is coming up in the gynecologist, and they do cervical cancer screening with the pap smear whenever they get an opportunity to do the local examination, the per speculum examination or per vaginal examination. So they take the pap smear from the cervix, and it is seen that with this opportunistic pap smear screening, so the chances of developing the incidence of cervical cancer is going down like anything. So same is with oral cancer also, because you have a very effective orovisual examination, which is very, very cost effective, and you can just train your health providers to do opportunistic orovisual examination in those patients who have a risk factor associated with them. I think this is the best modality which we can use. So to train everyone and to do opportunistic oral screening, oral cancer.
That's amazing. And doctor, I would like you to ask a little more about oral brush biopsy. As you just talked about the pap smear and opportunistic screening, could you please tell us a little more about oral brush biopsy, which is the newer and simpler way of detecting cancer?
So the thing is that whenever a patient undergoes a orovisual examination, so there are two kind of pictures which comes. So one is orovisual examination positive status and one is negative status. So negative status means the oral examination is absolutely normal. There are no erythroplakia, no leukoplakia, nothing is there. So but in orovisual examination, if you are able to find out some lesion, so then you can do further analysis of that lesion and you can do biopsy. So regarding the oral brush smear, so it is a newer modality. It is not available in general to whole of the population, but they take the smear out of the buccal mucosa and they analyze that whether there are any atypical cells or not. So I think these are something which is going to come up in the near future. But as of now, it is not very well taken up in the industry and in the government guidelines also.
Okay. Thank you. And so today we are talking about oral cancer awareness. But considering the current scenario in our country, we know that there is not a lot of awareness related to this topic. People are, I don't know what is it. Is it a social stigma or the cost attached to the treatments? So how would you like to address our audience to raise their awareness towards their oral health and hygiene?
So I think there are two aspects to that. First is say no to tobacco, say no to any sort of nut chewing, say no to alcohol. So this is your risk reduction strategy. The second thing is proper evaluation of any sort of lesion which is there, and to get a dental checkup done routinely. So whenever you face any problem, so any sort of ulcer which is not healing by 10 to 15 days time, so I think that is the time when you should consult your either dentist or ENT or any physician who can just look at the lesion and they can just examine it, whether it is hard or something, what are the probabilities of cancer, what could be other diagnosis also. So I think the second part is the proper evaluation of any sort of lesion, because most of these lesions initially they are benign only. So there are very, very less likely of getting a lesion which is cancerous. So if we see 100 such lesions in oral cavity, only 4% of them they are precancerous, and out of those precancerous lesions, only 25% of them they are the initial appearance is of precancerous lesion, and 25% of them they turn out to be cancerous. So you don't have to be afraid of or fearful of that you will get a cancer, because if it is a cancer, then the best way to go forward is to treat it rather than to keep it, and then it will become someday it will become loco-regionally advanced, and then you will need a major surgery. Then you might need a disfigured face of yours with the treatments which are available. So I think the better thing is to detect it early, to treat it early, so that the treatment becomes simple. Only one modality is used, and you do not get any sort of disfigurement in your face.
That's right. And would you like to tell our audience about some good oral hygiene measures that they
I think you are
practice?
the best person to deal with that. But yes, regular health checkups, brushing daily, using uh, like mouthwashes. So there was a concern with the mouthwashes also. So I'm not sure you are aware of it or not. So there was a concern that those people who uses a lot of alcohol-based mouthwashes, so they are also prone for oral cavity cancer. But but but
Because I think the regular use of mouthwash can lead to the necrosis of skin as well.
yes, mouthwashes is something. So if you have any lesion in your oral cavity, any infection, so that is the time when you should use mouthwash. You should not use it regularly. So first is brushing your teeth daily, in fact twice a day.
Yeah.
And the second thing is, if anything is there, just consult your dental surgeon.
That's right. So the way we brush our teeth is equally important. So the one while brushing, one should be very gentle with the way they are using the brush, and the gentle way, and always go for fluoride toothpaste. And flossing is equally important as brushing. And yes, as you explained, that avoid alcohol and avoid cigarettes. Yeah, that's it. And just stick to the nutritional diet. And I think, and also visit your dentist at least twice a year, even if one is not going through any kind of dental issues. That would be enough to maintain a good oral hygiene. So Dr. Jan, so that was a wonderful session with you, and we got to know a lot about oral cancer and the various cancers related to oral cavity. Thank you so much for your time and useful information. Thanks a lot.
Thank you, Rubia. Thank you, Epillo.
Dr. Rubia, could you please tell us a little more about Epillo HealthMate application and Epillo's retail health model?
Yeah, that's right. We have an application for Android users and iOS users by the name of Epillo Health Mate, where you can book your online appointments with the doctors present on our portals. And you can also go through various features which are available on the application, like medical advisory and drug food interactions and drug interactions to avoid the adverse drug reactions. So Talking about the upcoming health hub model, which is our retail health model. So this is going to be one-stop solution for all your health concerns. And Health Hub combines an ambit of health, medical, and wellness services such as pharmacy, primary care, preventive care, clinical diagnosis, medical advisory, and health counseling, and clinical laboratory services, etc., etc. At Epillo Health Systems, we want to help everyone to lead a healthier and a safer life through our various health products and services, which we are going to offer under our retail health model. Thank you so much. For more information, you can always refer to our website, www.epillo.com. Thank you.
Thank you, Dr. Rubia, for such a wonderful explanation. And I would request our audience to download ePillow Health Made now and stay tuned for more updates. Thank you so much.